this topic. We're getting started. It's a wonderful opportunity. We have a 50-acre campus in Round Rock, Texas. Is there a pointer? I don't see a pointer. Does anyone have a pointer?
Use the mouse. Can you use the mouse?
Ah, the mouse. I could use my pointer. Oh, there we go. Whoops. How do I go back? Goodness gracious. Back. No, that's not good. Does anyone know how to go back on the slides? The right one doesn't take us back. It takes us forward.
You can go your
No, you can't. See, we're going forward. There we go. So which key brought us backwards, Leanne?
That key.
Okay. And here is Round Rock. Round Rock is a suburb directly to the north of Austin. Austin is apparently the most rapid growing city in the United States, growing about 3% in population per year. And Round Rock is one of the most rapid growing small cities in the United States, population over 100,000. Projected population of 1 million by the year 2020, I've been told. You can see here that there actually is a round rock. It's in the center of a river, and it was a landmark for the cattle drive. Meet you at the Round Rock. And that's how things got started. Here's our school, and here we are. We very much are beginning. We would very much love to have a person and people-centered school, educational program, and service mission, and we really would like the widest possible collaboration, suggestions, criticism from our colleagues as we do this together. Okay, I'm going to give some background here. In 1910, it was rather easy to develop a medical school in the United States. We could all do it together. We have a number of experts here. We could all put some money together and buy a building and set up a curriculum and train students and send out Doc Holliday to practice in the West and teach people how to use whiskey and surgical instruments. And there were a large number of schools of varying degrees of quality, some quite outstanding like Johns Hopkins, others less so. Substantial numbers of minority and women's medical colleges. It was a very nice way to train doctors, but it was chaotic, and the Rockefeller Foundation and Carnegie Foundation decided to reform this, hiring a young gentleman by the name of Abraham Flexner. There he is here. And he really did his job. He visited every one of these medical schools. He went all over Europe, to Edinburgh, and to Paris, and to Germany. And he learned about scientific medicine, about microscopes and germs, and just came back with the Flexner Report, which created American medicine the way it is today, as a fully scientific system based upon laboratories, dissection, with standards. The American Medical Association was empowered at that point. It really had no power before that to certify the competence of doctors. So licensing exam, uniform standards, and all of the old forms of medicine that were animating the medical schools, the folk medicine, the sectarian schools, were all ended. Within several decades, the majority of schools closed. And it truly was a massive cultural accomplishment for Flexner, a triumph for bioscience, statistics, and epidemiology. This is Flexner in his later years when he was the founding president of the Institute for Advanced Studies in Princeton University. And it was Abraham Flexner who wrote the invitation letter to people like Albert Einstein, to come to the United States. So this man has a very distinguished career, and we are still living in the era of Flexnerian medical school. And it's the idea that you need a broadly educated person, typically a man after Flexner, not so before. Typically someone with money, because you have to pay for 4 years of college, university, and then 4 more years of medical education, and scientifically educated. Suitable preliminary education, uniform degrees, and we have here what I'd said earlier, professionalism, scientific conviction, admission criteria, libraries and laboratories, apprenticeship. Flexner was very big on apprenticeship. You needed mentors and teachers and standardized examinations. Now, when it comes to the issues that might also help us become more rather than less person-centered, the Flexner report had very little to say. Flexner did say that a doctor should be an educated man. Practitioners deal with 2 types of facts, he said. One would be chemistry, physics, biology. These are the basic sciences. But you also need a different apperceptive and appreciative apparatus to deal with other more subtle elements. In this direction, one must rely for the requisite insight and sympathy on a varied and enlarging cultural experience. That's all that the Flexner report had to say about humanistic qualities, qualities that might relate to relationships, relational qualities, that there really wasn't much to say other than a broad education guarantees, as best as we can say, an educated man. And by the way, he said man, of course, but that's what everyone would have said at that point. There was no notion of person. Furthermore, he did say that there's a lot of ethical responsibility and that the physician's function is fast becoming social and preventative rather than individual and curative. So there's an anticipation here for person-centeredness. And upon him, society relies to ascertain and through measures essentially educative to enforce the conditions that prevent disease and make positively for physical and moral well-being. So even in the Flexner report, although it's a single paragraph, that's all that you can find in this long report, there certainly is the ethical and moral responsibility to promote health as well as treat illness and disease and to prevent disease and to promote positive physical and moral well-being, rather ahead, I think, of his times. I'm just listing here, it's not just Flexner. Many other people have talked about a person-centered medicine. Osler, the good physician treats the disease, the great physician treats the patient who has the disease. Hippocrates, more important to know the kind of person rather than to know what sort of disease a person has. Jean Hamburger, is he well known in Europe and France? There's a wonderful paper about him in the literature just this last month or two in a journal called Philosophy, Ethics, and Humanities in Medicine. He is the founder of the medical intensive care as we now know it, and the first to propose the name nephrology. So here's a medical internist, so you do, And he actually talked about how important, first of all, that hospitalized patients do not feel that they are anonymous and deprived of their personality. It is wrong to say this patient or this kidney. Patients should not only be called by surname and first name, but physicians and nurses should know that Mr. Stéphane Dubois, excuse me my French, is an art bookbinder, that he loves his job, that he has a charming fiancée, and that he is a passionate reader of... Yes. I point this out because this is not a psychiatrist. This is a critical care, intensive care nephrologist. And I think that's important. Here's George Engel, who I had the privilege of knowing as a younger doctor, whose biopsychosocial model I think is somewhat neglected today in terms of its relevance to person-centered medicine, but it was an effort to create a broader approach to medicine. And you see that it emphasizes health. at the focal point of psychological, sociological, and biological domains. And notice that Dr. Engel was very careful to put the person in the center. And these are general systems that go down, cells, organelles, molecules, atoms, and go up, two persons, family, community, culture, subculture. And you see the way Engel nested them, he put the molecule at the most basic level. I mentioned today in an earlier symposia that a younger and less wise Michael SCHWARTZ took this on, head on, in an article in the Journal of Philosophy Ethics, in a journal a long time ago, basically saying that this is problematic. These are general systems indeed, but these systems down here are not more and more basic. They really are more and more abstract. Right? In order to think of tissues, we have to abstract from persons and bodies and thoughts and feelings and emotions and focus on a few things which are relevant, what's relevant to tissues or cells, and ignore all those other things, and that these systems, which really have been called more and more basic, should be seen as more and more abstract. And we wrote some other things, which I'll get to in a moment. I will say that the wonderful thing about George Engel was that when we sent this paper to a journal, of course, we were young and inexperienced. We didn't realize that he would be the reviewer, of course, because the paper is about him. Most reviewers in his position would reject the paper, right? That would be the end of it. Dr. Engel wrote to the editor of the journal saying, you know, I want to talk to these guys because they're onto something, but they're so harsh and critical and they don't understand me at all. Why in the world didn't they call me before they wrote this paper and talk to me and learn about what I was trying to say? Then they would have written a better paper. So can I withdraw as a reviewer and invite them to visit me in Rochester and we can talk about medical practice? So that was the benefit of writing this paper, learning about what a real mentor can do as compared to a politically motivated person. And we had some very interesting conversations. And this is where we wind up. I want to point out that on this hierarchy of systems, where does medicine fit? And if this is the most abstract level, what is the most concrete level and the most basic level? Well, the first question, where does medicine fit? It doesn't fit anywhere. It doesn't fit anywhere because it's not a pure science. Medicine is a practical science. It's a pragmatic science. And therefore the goals of medicine are not to understand a system or a part of a system or a complex system. The goals of medicine are to promote health, prevent illness, treat disease in persons and people. That doesn't fit anywhere in the hierarchy. Practical sciences, humanities, and arts don't fit on this hierarchy of pure sciences. And the most basic level is actually, if you redo this, here's the most basic level. The most basic level is the most concrete level, and the most concrete level is this: our interaction with each other in our life at this moment, in the here and in the now. And from this concrete level, which is the most basic level, basic being concrete, they are really the same, we constantly abstract to have a conversation, and in a very methodical way, we abstract to do science. So there's a hierarchy of science, and by that, sciences become more and more and more abstract. And more abstract sciences have very specific rules for gathering evidence. and they are typically mathematical and statistical, more and more concrete levels of science can use abstract methods, but at their essence, they cannot be abstract. They have their own rules, they have their own evidence. For example, language is not a very abstract level of science, but if you don't think language has rules, try to speak French or German, and you'll very quickly discover that you're going to come up against rules. But that doesn't mean it's like physics. And the point is that it's always a question of fitting the different sciences into the practical jobs of the doctor, whether that be promoting health, preventing illness, and treating disease, and getting it right in terms of what is the right scientific approach to the problem, and learning how to be critical about that approach. And that's what I hope we can bring into our school. So this just points us, I'll stop in a couple of minutes, this just points that physics is actually our most abstract science, and it arises because much of reality is set aside in order to do it. Physicists abstract from meanings, values, intentions, feelings, the social world, the human world, and part of the living world, in order to isolate physical reality. The gain is exactitude and precision, but the loss is that we're only referring to certain parts of reality. Human sciences are more concrete, more abstract, closer to everyday life. There are rules, I'm not going to go into them because of time. I think the issue about an evidence-based medicine, which I think is important in person-centered, is I think we have to integrate the two domains of evidence-based and person-centered. I would just say that there isn't an evidence-based, but in addition to assessing evidence, we always need something equally important, which is neglected, which is a critical attitude about that evidence. Is that evidence the right evidence for the problem? Or does that evidence really work better at another level of the system? And the main problem with evidence-based medicine, as I see it today, is that the hierarchy of the evidence does not take into account this need for a critical attitude about the evidence. Second point is the notion of the practical science. I mentioned that. I'll just stop here. This problem of confusing levels of evidence and confusing abstract with concrete has been called by Albert North Whitehead the fallacy of misplaced concreteness. It's something we all experience and suffer from in our culture. It goes back hundreds of years, and you could trace the origin to Galileo and the struggle between science and culture at the time and the resolution with Cartesian dualism. It's something that I think we have to overcome in order to have a person-centered medicine. A person is as mental as he or she is physical. They're both, they come together, and this scientific schema, I think, can achieve that. So I'm going to stop here. What I'm hoping to do is to have our colleagues from our medical school explain some of our perspectives and viewpoints on person-centeredness, and then really, again, to have all of you help us as we develop our center as a person-centered medical campus. Thank you.